Hello there. Today I've got a practice station for you for the MRCOG Part 3 exam. You can practice this station with me. Now this is a structured discussion station from the post-op module. What we're going to do, the way it's going to be split is I'll put out the questions on the slides for you, and then we'll go through the answers. The next slide that will follow will be with the case study, and then I'll give you a couple of seconds just to think about everything in the case study, and then we'll follow with the questions. Now, when I do put up a question, I'm going to give you just a couple of seconds to think about the answer, and then I'll follow it with the answer. So if you want to take more time on it and think about it, then I suggest that you stop the presentation at that point and then replay it once you're happy with your answer. But don't give yourself more than 10 minutes for the entire station. You are SD5 on call and you have been called to ED to review a patient who is 6 years old and had a routine hysterectomy 2 weeks ago. She's now complaining of loss of bladder control and vaginal wetness. You have 10 minutes to answer questions by the examiner. So the first question is, what diagnosis do you suspect? And the potential answers to this is, so she's coming with loss of bladder control and also vaginal wetness, and she's had surgery quite recently, and this is a post-op station, like a module station, so you know it's got to be some sort of complication of surgery. So one of the things is it could be urinary tract or vaginal fistula. So it could be like a vesico-vaginal fistula or a uretero-vaginal fistula, and it could also be a urinary tract infection or pelvic hematoma and abscess. Next question, what are your next steps to confirm your diagnosis? So, in order for you to get to any diagnosis, you need to really be able to get more from the history, because there's very limited history given to you. So, you want to take a history, perform a pelvic examination. You want to do a midstream urine sample, send it off. You also want to take a HVS and send that off, which is high vaginal swab. Um, you can also do something called the methylene blue installation to bladder, and then visualize that by actually looking at the vagina, or putting a swab in the vagina. And if you see any of the methylene blue draining onto your swab or just draining into the vagina, then that confirms the diagnosis of a fistula. You want to admit the patient for further imaging. You want to also consider doing a pelvic ultrasound scan, which will help rule out things like an abscess or a collection. You want to think of doing a micturating cystogram and a IV urogram, which will help pick up any of the ureteric injury suspicion, and things like that. A small vesico-vaginal fistula is confirmed on micturating cystogram. IVU is normal. What are your next steps? Now, in this case, you want to inform the consultant, you want to contact the urologist because clearly it's not your area of expertise, and you want to inform your patient. What would you tell the patient? Just going to give you a couple of seconds to think about what you may want to discuss with the patient. So the patient needs to be informed as there is a duty of candor to the patient. Patient needs to be apologized to. You want to tell the patient that this complication is infrequent, but it's a recognized complication. You want to explain to the patient why this has happened and also what will the care following this involve. Why can a vesicovaginal fistula occur? So you can explain to the patient that the bladder is close to the vagina anatomically and for example, a misplaced stitch sometimes can incorporate the bladder onto the vagina. There also can be avascular necrosis as a result of infection or hematoma. So that might not be apparent straight away, but that's something that may develop a few weeks after the operation. Last question: what would you do after, in terms of aftercare, after care has been taken over by urologists? So you want to follow up the patient, review the patient regularly as an inpatient. You also want to see the patient in gynecology outpatients to see how she's recovered and how she's getting on after the hysterectomy and the complication. You also want to uh, inform the clinical governance and acknowledge unexpected complication. So most trusts have got a clinical governance meeting where they present their rare complications so that learning can be taken from this case, and it also helps in preventing this from happening in the future. Well, that's it really. So that was a vesicovaginal fistula question, quite an important question. The questions in the exam will be quite straightforward and will be put out to you just like this one, where you are initially given a case study and given a couple of minutes to think about it, and then it'll follow with the questions. You can take as long as you like on the questions, but bear in mind there are more questions to follow. So you don't want to take an awfully long time on answering one question, which then prevents and stops you from getting on to the next questions, which may or may not be easier, but it may be where you can get some extra points as well. I hope this sort of format was useful for you. I thought it'd be quite useful to just go through a station and see, and also for you to start getting your mind into the focus of the exam. And also because it's followed with answers straight away, you can then think whether you got the right answers. Now, if you did find this video useful, then please do give it a thumbs up and press the subscribe button because I'm going to be sharing lots more stations with you. um, Now, do drop me a comment to tell me whether this station format was useful for you or whether you wanted to be altered in any way.